Good morning, everybody. Welcome back to session 2 of this 3-session webinar on sort of intensifying your understanding of the home and community-based services level of care determination. I'm Susie Button. I think most of us met yesterday, and I'm co-presenting today with my partner in crime, Josh Nellis. He's going to introduce himself and give you a little bit of a refresher on the tech today. So just a little refresher on yesterday's learning objectives. We took a look at the practice and measurement models that inform the use of the tool, and we looked at how that big picture look at the HCBS eligibility determination and the algorithms themselves. Today we're going to focus in on something a lot of you sent in questions about, actually, the HCBS related items specifically. What are each of those items all about, and some tips and tricks on how to assess for those pieces of information. We're also going to, later in the webinar today, look a little bit at the TCOM care coordination model. How can you use some of the information that derives from the CANS items that you rate to focus in the plan of care? And we're really going to talk a lot about those extension modules and how critical they are in terms of the information for the determination of eligibility, but also for good, strong care coordination. We want to make sure you walk away with that link. And here's a little overview of what we've been doing, right? So yesterday we looked at TCOM and the key characteristics of a Computometric tool. Today we're going to take a look at those items and the care coordination model. And we asked you to do a little bit of homework to be able to review that Charles vignette. And tomorrow we're going to have some Q&A time. And so we really want to encourage you. We've gotten, as Josh said, a list of really great questions, but we want to encourage you to ask more. So before we move into content today, I really wanted to check in with everybody in terms of what was helpful yesterday and what do you need from us today. And I'd like to encourage you actually to either chat, but preferably let's hear everybody's voice today. We would love to hear some talking today. We had a great conversation on yesterday's webinar. People used their cameras yesterday in the afternoon more frequently, and that really makes for a more positive environment. So we really want to encourage you to do that today. But let's start out with a few simple questions. So number one, if you would just chat in whether yesterday's training was helpful, sort of marginally sort of helpful, or, could have had a better use of my time. What did you think? If everybody could just chat in an answer to that question. Helpful, Monique says. Ira says very helpful. Everybody's saying helpful. Michelle, good. Review is helpful, Michelle. Yep. Rebecca, thank you. That's very sweet. I've got some folks I haven't heard from yet. Ali, 100% useful. Oh, I'm glad to hear it, Ali. Thank you. How about some of the other folks who haven't chatted in? So looking for Lisette. Looking for Carolyn Jones. I'm looking for Amanda. I'm looking for, oh, great, Carolyn, thank you. Caris or Caris, I don't know if I'm butchering your name, but I'm looking for you all to be part of this conversation. Amanda, yes, very helpful. Great. Okay, glad to hear it. So we're going to try and be as helpful as that today. And we're going to launch now into the content. Remember, throughout the morning, first of all, please feel free to enjoy Josh's very adorable daughter, Esri, who's on the screen right now. She's kind of amazing. And also try and pay attention because I find myself easily distracted by her beauty. So let's launch into some content now. Here she goes. he's waving. Before we get into the content, I just want to reiterate what Josh said, which is this goes better when we have discussion. And so please don't hesitate to raise your hand, to chat into the chat box. You can chat to everyone, but you also can chat privately to me or to Josh, and we can answer your question anonymously as well. So please feel free to stop us, to throw in examples or questions as we move through. Today, I really want to hone in on the items themselves, right? The reason being, right, when we think about the domains and the modules and the structure of them, we want to think about what we talked about yesterday, which is that big picture of what HCBS is for and why the eligibility items were chosen, right? So we're drawing from different places on the tool, and we're doing that because we want to take a look at how certain needs that tend to lead to restrictive placement interface with functioning and development. And we want to make sure that kids who are really at high risk of restrictive placement or in a restrictive placement get access to those higher end, higher quality community-based services when needs start really getting in the way of day-to-day functioning. So let's take a quick look then at where we pull from, and you'll start to see when you think about that approach, you'll start to see how it makes sort of a clinical sense, right? So the purple domains and modules are those that relate only to the HCBS SED determination, yeah? So we're thinking about caregiver capacity, which makes a lot of sense when you have an SED kid. It really is, has a particular set of nuanced skills that are required for kids with behavioral and emotional challenges, so we definitely look at some of that. We also look at child strengths in that SED determination. And what we want to be thinking about there is, right, strengths mediate difficulty. So with an SED population, the presence of strengths is very much indicative of good outcomes, yeah? And then we also obviously look at those two areas of functioning, right? Child needs and functioning, which is that broad domain that focuses on overall functioning at home, in school, in life, yeah? So we want to take a look at some of the select needs there. And we look at functioning in school. Again, select needs from each of these domains that are considered the critical areas where if kids aren't functioning well, right, that tends to lead to sort of that domino effect, right? They're not developing well, they're not functioning well, they're not thriving, and then, right, risk of placement gets higher and higher. And obviously we look at risk itself because high risk behaviors are those that tend to lead to restrictive placement. And then when you get over to the extension modules, right, we're looking for those SED determinations at trauma symptoms and behavioral health, right? So if you just look at the purple, you see it makes a lot of sense. We're taking a look at what we might traditionally think of in our clinical medical world as symptoms, right, of psychiatric challenge. And then on the other side, we're looking at functioning, okay? So now I want you to shift your eyes to the red. And you're gonna see the red is a little simple, right? A little more simple, right? This is the med-frag determination, right? These are where these items come from. So the medically fragile DD population is a very different population than the SED, as you all well know. You're all nurses, and many of you are seasoned in both psychiatric and medical populations. But the reason this set of items is more simple is because we really do collect a lot of other information about the actual medical needs that a child has. The CANS is a functional tool. The HCBS determination is a functional determination. And so here we're looking at two core areas, right? We're looking at those medical health module items, which really are the impact of the medical diagnosis on the child and the context, right? So we're looking at items from there, and we're looking at self-care activities of daily living. That's really the core focus of function here, right? We really want to say to ourselves, how is the daily functioning going given the impact of the medical diagnosis on the child? So that's sort of the two, right? And we really want to pay a lot of attention to these extension modules, right? They come at the end of the cans. Most of the items in the HCBS determination are drawn from them. But as we saw yesterday, right, when we see information about symptoms, right, we really, really understand that we have to start thinking about functioning. So I see a little question here. Heather is saying, when a child is enrolled in a health home, are they required to complete the cans? Yes, Heather. So remember that picture yesterday that we saw of the three partners in making sure kids get the right dose of care. You as CES evaluators were in the middle there, right? You have the subset that you do and your comprehensive that you do. But in the health home serving children system, in order to enroll a child, the care manager has to complete an initial CANS. The plan of care has to be rooted in that full CANS, and every 6 months that CANS needs to be updated. So yeah, that's a difference between the two, right? You're welcome. And so, you know, for you all, you're sort of, what I would recommend that you do is you think about the structure of the overall tool and your comp assessment as a closet organizer, even though you don't complete it. Because remember yesterday we were talking about, we would see some symptoms in the examples and then folks would start asking lots of questions about functioning and context, right? Because you're all, right, you've all worked clinically for a while. So when you start rating these key items, you are going to have questions about functioning. And even though you don't necessarily rate all of those items of the CANS for the HCBS determination, the information you would need is going to be critical for a good understanding of what needs to happen next. And we'll talk about some examples in a minute. So we're going to separate out the two now, and we're going to sort of walk you through a process of really digging into each eligibility determination. So we're going to start out with that serious emotional disturbance, what we're calling the SED level of care determination, and we're going to look at the treatment needs and the functioning of an example child in that determination. First, let's take a look at the items themselves, right? So, you know, we're going to look at the trauma symptom module now. I want to preface this by saying that, you know, I've looked at a lot of sample cases from the population that you all are serving, and also from the larger health home population. I've worked with the TCOM tools for a long time. And there's a similarity between the TCOM tools and clinical assessment in general, in that trauma symptoms in children tend to be very difficult to assess, right? And so when we see problems, either overrating or underrating, right, they often hang out in here. And that's because people might assign trauma symptoms to a child who doesn't necessarily have trauma symptoms, but also because trauma symptoms are easy to miss and easy to see as other challenges, right? So we're going to pay some special attention to trauma symptoms today. So the trauma symptoms module, right, you all know these are needs that may be linked to known or unknown trauma that impacts functioning, okay? And so what we want to look at today is, okay, what are some typical assessment questions that we can hold in our heads and that we can use with the child and the family to help us find out this information? So the traumatic grief item, right? That's intense grieving related to loss and trauma, right? Intense grieving related to loss and trauma. So a child, for example, yesterday we had an example of a youngster who had lost both parents in the Sudan. He was 5 or 6 years past that experience, but one can imagine that he might have had some level of traumatic grief after losing his family, right? So some of the questions to sort of consider when you're reading records and talking with youth and family, right? And now I want to point out, these are questions to consider in your own head. The way that you might talk about this with a youth or a family would be a little more responsive to their style of communication, right? But you want to be thinking about, talking about, looking at records to identify evidence that the child or youth shows an intense level of sadness, preoccupation, or anxiety about a lost loved one, right? Now, I want to point out that this symptom is fairly normal after a loss, right? And it can be something that happens for a little while for every child, and then sometimes it can sort of get into a stuck pattern, right? And so when that grieving process gets stuck, it can start to interfere with the child's functioning and development, right? The child is unable to engage in joyful, interesting, curious activities, might be unable to connect to new people. And so it's important to sort of think about not only is the sadness there, but how is it interfering with functioning? So that's traumatic grief. Re-experiencing is a very specific trauma symptom, right? So we have heard this referred to as flashbacks, right? When I was in my training many, many years ago, I worked with combat veterans, and combat veterans actually sometimes, not all of them, but those with PTSD experience actually vivid flashbacks of experiences that they had in combat, right? So re-experiencing for a child is often very difficult to identify because children can't tell us the way an adult combat veteran does, I'm seeing this thing that happened to me. So instead, we sort of look for signs that the child is communicating that re-experiencing to us. With a younger child, that can look like nightmares, where they have nightmares, or repetitive play. So a great example of this is a child I worked with many years ago whose house had burned down, and whose father had died in that fire. And she repeatedly acted out scenes of houses burning down, monsters coming and crashing houses down, tractors coming and plowing houses down. And it was very clear that she was really struggling with memories and visions of that experience at her young age, right? And often, right, an older child can tell us they're having flashbacks, right? And they may not define it as such, but we're likely to hear them say things like, I think about it all the time. I see my abuser. I can't get the smells out of my head, right? So flashbacks are not always visual. Sometimes they are associated with smell or sensory experience. We had one child that we worked with in one of our residential programs who wore layers and layers and layers of clothing to bed, and she would not agree to sleep in pajamas. And when we really started talking with her about what that was all about, she said that when she couldn't sleep unless she had layers of clothing on, because she had learned from her childhood that she could prevent sexual abuse if she had those layers of clothing. And the memory actually that she was stuck in was, I'm only safe if I have 10 layers of clothing, because I remember someone coming along and saving me before all the clothing was taken off. So we want to be thinking very creatively about what re-experiencing looks like. We also don't want to assume that re-experiencing is happening simply because it's a very specific kind of a symptom that requires a specific kind of a treatment approach, right? And we want to think about how often does this occur. For some folks with trauma histories, these kinds of flashbacks can be relived under periods of stress. And for some, it can become more chronic and can actually begin to interfere with normal and healthy development. So I just want to pause as we go through these items, and I want to check in any questions on either one of these before we move to the next set of items. Okay, so remember, you can just jump in at any time. Let's take a look at a few more trauma symptoms. So now here's another symptom that's easy to misunderstand and easy to miss, and that's this symptom of hyperarousal. Okay, so hyperarousal is actually a physiological state. It's not a mental state. It's a whole central nervous system state of exaggerated stress response, right? And so what it can look like is exaggerated anger, right? Often a very irritable kid who loses their cool for no apparent reason, right? That could be hyperarousal. a startle response, children who are easily frightened, right? And the other piece of hyperarousal is hypervigilance, right? And so a lot of times this is missed in adults because it's seen as some sort of paranoia. I have a friend who's a combat vet, and he likes to remind me when I tease him and say, "Stop being paranoid," he'll say, "That's hypervigilance, Dr. Buck." Right? That's what he likes to tell me, because it isn't actually paranoia. It's a learned response. It's very physiological, that if you keep your head up and your eyes out and you look for what's happening that might be dangerous, you might be able to avoid it. Okay. These are very physiological responses. And so in kids, we want to sort of look at their whole physiological state. Do we see or hear about an unusually intense startle response, right? Does the child have physiological responses like stomach aches or headaches in response to a normative stressor, right? So something like the child gets spoken to sternly at school and then develops a secondary symptom, right? Does the child show unexplained bursts of anger or irritability? And finally, we're always looking to say an actionable need is a need that gets in the way of healthy functioning and development. But one thing I want to sort of throw out to the group is this. When you look at these questions and these signs of hyperarousal, what are some other items that might be confused with this one? What do you think? There's some on the behavioral health side that we could easily suspect when we see some of these same, right? So Eliza is saying psychosis. Yep, we could be thinking about psychosis. What else? Attention seeking, right? That's a terrific one, right? And that's actually anxiety, Heather is saying. OCD, right? The stomach ache and headache can certainly be that. Yeah. How about bipolar disorder? How about mood disturbance, right? You could also see that, right? So you see how easy it is to confuse some of these things, right? And so what we want to be really careful about, because we have a long history in our field of actually missing trauma symptoms, is when you see something, impulsivity, Catherine is saying, when you see something that might be hyperarousal, that's a sign, as we talked about yesterday, to start really trying to find out more, trying your best to make a differential approach to the rating of the item. And that's because, right, if it is hyperarousal, it's something we can actually treat. You can really treat that nervous system response. And, we all know the nervous system's more plastic when children are young. So let's take a look at avoidance. Avoidance is actually often fairly easy to identify if you're looking for it, right? So avoidance is simply this. It's an effort to avoid things that are reminders of that traumatic experience. So where this gets tricky is that often a child does not have any insight into that avoidance, right? And so what you'll start to see, for example, is, right, a child who is systematically abused by someone who they care for a great deal will begin to avoid attachment and interrelatedness with other people. And people start seeing that as a difficult kid. My least favorite diagnosis in adults is borderline personality disorder, because this is one that we really see is misdiagnosed in women who have childhood histories of trauma, right? And so we really want to be detectives about this one. Are there behaviors that are confusing to understand, right? So a child who blows out every single time that a certain physical type is in the room, right? A child who will not go into the bathroom, which is a common place where abuse happens. A child who deteriorates every night at bedtime, right? Avoids going to bed, right? These are the kinds of things that we often think about as, well, it's a problem with the environment, it's a problem with oppositional behavior, right? Maybe it's anxiety, and certainly it probably is anxiety, but if a child is systematically responding to certain people, situations, or places with any behavior that's avoidant, that's when we want to become those detectives again. And we really want to dig into finding out or learning more about what that behavior is about. Now, and really, I'm understanding too, right, that your role doesn't necessarily give you that freedom to sort of openly assess. But if you find yourself unable to explain an avoidance behavior, that's when you want to be thinking about recommending, right, more evaluation or some kind of trauma-focused treatment. So let's go into a few more trauma symptoms. Again, these all contribute to the SED algorithm potentially, right? So numbing is one that can also be easily confused with other things, right? Numbing is a reduced capacity to express a range of emotions, right? So when a child does not show a developmentally appropriate range of emotion, or we see a change in the child's emotional style, right? That's where we want to start asking questions about numbing. Now, so let's think about this. What are some other things that could cause a child to be flat, right? To be emotionally flat? And Ali, I'm going to come back to your question. Right. So I'm coming back to you, Ali, in just a second. Yeah, good. So Carolyn is saying autistic spectrum disorder, depression or underlying physical illness, right? Metabolic illnesses can make a person flat, right? Good. So this is where we don't want to make an assumption about the flatness, but we don't want to attribute it to one thing or the other until we're really certain, okay? I want to back up to Ali's question. Very good question here. So Ali's asking a question about avoidance. I'm going to just jump back to that slide. So Ali says, is it normal for avoidance to want to avoid places, persons, or situations that remind you of a traumatic experience? Is it normal for a child who wants to avoid a person or place? So Ali, from my perspective, I have some challenges with the word normal, but I do like to think about, is it adaptive, right? So for avoidance, if you have a trauma history, it is adaptive for you to learn to avoid things that trigger that hyper arousal response, right? So what we said just a minute ago was when we have a hyper arousal response, it's not our choice, right? Someone has a trauma experience or repeated trauma experiences, and their actual rate, the research tells us things like their L-cortisol level, their skin conductance, right? Certain brain responses become actually exaggerated or heightened on an ongoing basis. And so avoiding things that push that up, right, is very adaptive because it's not healthy for the body to operate at that level of stress. The problem with avoidance comes, right, when it becomes not a tool in a trauma survivor's toolkit, but a habit that interferes with healthy development and well-being, right? So, for example, we talked a few minutes ago about someone who might have a sexual abuse history or a chronic abuse history at the hands of treasured caregivers, right? If they start to avoid deep connection and relationships with other people, what happens, right? Well, they become devoid of some of the very things that feed healthy development, well-being, and safety, and so that can become a cycle. So when we look at avoidance and we work in a trauma-focused way with kids, what we start to teach kids is something called, it's sort of like a graded exposure, right? That we want you to learn to approach things that remind you of your traumatic experience, but are not actually going to be traumatic for you. So we're going to teach you how to identify the difference, and we're going to teach you how to keep yourself calm as you approach. And then in the end, we're going to teach you that you actually can learn to identify things that are not going to be good for you and avoid those, but to move toward things that are going to be good for you. It's a great question. Thanks, Ali. So let's get back to these items. We're going to look at dissociation. Okay, here's another one, right? Dissociation is a pattern of spacing out, distancing, detaching, or changing personality linked to a traumatic experience, right? Again, another thing that's very hard to spot, particularly in younger kids. So things to look for is the child space out or forget more than is developmentally appropriate, right? So one thing to think about, though, is what's another reason why a child can space out or be forgetful? What's another diagnostic reason? Chat that in now, if you would. Right, so inattentive, right? ADD, neurological issues, ADHD, right? So that pattern of spacing out, right? Kids with seizure disorders too, right, can look very spaced out periodically throughout the day. So this pattern of spacing out and distancing and detaching is something that is not explained by another diagnosis, right? And it often looks different, right? And this is sort of the hard thing to teach, and you're not, right? But it looks sort of fearful, or like the child has sort of totally left their body, as opposed to looking like the child is thinking about something else. Or in a kid with seizure disorders, right, sometimes kids can look spaced out but not anxious, right? Another piece that can happen is kids rapidly change personality, right? So they act very different in different situations, right? And so we can look at that as a possible clue. And again, right, you see that because there's so many other things that can be confused with this, or that this can be confused with, that we want to be detectives and we want to be careful about this item. So another very important item, and again, these are so tricky, right, is this dysregulation piece that comes with trauma. So remember a few minutes ago, we talked about with hypervigilance, right, that hyperarousal, there's that actual physical heightened arousal that comes with trauma, right? And so that also can lead to this sort of extreme fluctuation in energy and emotional states, right? Notice though, just as we've been discussing with the other items, this is unexplained by other factors, right? So when a child has extreme or unchecked reactions that are out of proportion to the situation, right? So a child who tantrums over something that's very tiny in a very extreme way, any individual who loses their cool when something triggers them, right? So again, the tricky thing here is that children can't tell us what their triggers are. And so as detectives around trauma symptoms, we're really looking for these changes that are sort of unexplained by other clarified diagnostic issues. It's easier when we know there's a significant trauma history, right? Because we can then start to sort of parse out some of the links between these behaviors and the actual trauma experiences. But when we start to see a couple of these things, and we start to suspect that there are more than one of these items happening in the child's functioning, even if we don't know about trauma, that's when we really want to be thinking about trauma-focused treatment and evaluation for a child. So we're going to take a look at an example next, but I want to pause before we move to the example and just check in with the group. Any questions about any of this? Okay, just keep on jumping in whenever your questions come up. So let's take a look at an example, okay? Here's Ginny. She's 8 years old. And notice, just like yesterday, when we're talking about an example, we're going to color code it a little bit for you so you can start looking for evidence associated with the items that you're going to need to rate for the determination of eligibility for SED, right? But we're also nesting those items in this child's larger story, because we can't separate those out when it gets to time for a plan of care or action. So here's Ginny. She's 8 and she's experienced significant abuse and neglect as a very young child, but she was adopted by her new family last year. Ginny's had difficulty building a strong relationship with her dad. She avoids interacting with him as much as she can. When she's asked to come to the table for family meals, Ginny refuses, and she becomes rageful if her parents insist. Her father says he's finding it difficult to build a healthy connection with Ginny, and her unpredictable outbursts of irritability and anger are impossible to handle. Ginny told her therapist that her dad reminds her of her abuser and she doesn't want to be around him. And Ginny's teachers say that she frequently spaces out at school and that it seems at times like she's very detached from what's going on around her. She's difficulty paying attention to what she has to do, what the teachers are teaching, and even at times she seems to forget what class she's in. All right, so let's chat out now, right? Thinking about those trauma symptoms we just reviewed. What are folks seeing in this example that they're now tempted to think about rating? We don't need to think about an action level, right? From that list of trauma symptoms only, let's focus on that, right? Avoidance, Brianna is saying. Yeah, everybody's saying, Heather, avoidance. Yeah, absolutely. And re-experiencing, right? And dissociation, right? We're seeing an example. Great, guys, right? Avoidance and dissociation and re-experiencing. We're seeing a clear example of a child who's really triggered by the presence of her father, right? And she is hyper aroused, right? Heather just typed that in. Good, right? We're seeing these sort of unpredictable bursts of irritability and anger. That's that dysregulation, right? That's not necessarily a sign of hyperarousal, but we want to sort of make sure that we check in on that. But we definitely see dysregulation, okay? So what we see, oops, sorry, I did not mean to do that. What we see with this piece of Ginny's story is that clearly, right, Ginny is struggling with being triggered around certain activities, particularly her relationship with her father, and that there's some sort of a physiological state where she numbs out in the school environment. So for Ginny, right, what do we want to be thinking about in terms of if she makes it through the HCBS determination, what are some of the services we want to be thinking about for her, right? We want to really make sure this family gets back on track. We really want to help Ginny retrain her mind and body so that she can connect to her dad, right? So these are the sorts of things we can really get going when a child is this age and prevent significant problems down the road. So, I think I just clicked myself. So this is the behavioral health module. It's really not continued. This is actually the first slide, so ignore that. I don't know where I was when I typed this slide. So we're going to switch now to the behavioral health module, right? And so again, we're going to see as we go through these that many of these can be easily confused with trauma symptoms. And so we're always wanting to be detectives. We want current information. We want good information, and we want to have a lot of conversation with the team we talked about yesterday to sort of get some clarity on what's going on with a child, to make sure that our ratings are accurate and our plan of care is targeting what's really going on. So the behavioral health module is our things that you all as nurses are probably well trained in, right? I know many of you have a lot of depth in psychiatric and mental health settings, right? I remember that from our time together last year. These needs are really often associated with a DSM diagnosis, right? But sometimes you don't have a formal diagnosis and the symptoms are impacting functioning. And so it's not just reviewing for the diagnosis, but it's also taking a look at functioning and how some of these things might be present. And as you know, I actually did a case review from the CES population last week in which a child's diagnoses changed 3 times in a year over the course of 3 hospitalizations, right? And what we also know with DSM diagnoses is that they're tremendously unreliable. So we really want to be making sure that not only is the diagnostic label there, but the functioning matches and the treatment referrals are going to want to match the functional issues. So let's talk about psychosis. In children, psychosis generally should be rare, right? Symptoms of a formal thought disorder that are not associated with an underlying known neurological base, right? So this is the classic symptoms of psychosis: hallucinations, delusions, right? Bizarre behavior, right? And that these get in the way of healthy functioning. I'm going to take a minute, right, to remind you about one of the key principles, right? So we take development into account when we assign an action level. So Josh has a very adorable son who you probably don't right now see in the background. Oh, there he is. There's Isaac, right? So Isaac is he 5 or 6 now?
He's 6.
He's 6. So if Isaac comes up to Josh in a few minutes and says, "Daddy, me and the big green dinosaur are playing dance part. So you want to be a ballroom dancer in the living room, and the big green dinosaur just won. Should Josh be worried? Is that a sign that Isaac is exhibiting psychosis? No. That's a sign that Isaac, well, and we already know this about Isaac, has a very good imagination, is a very bright, creative kid, and is learning to entertain himself with his imagination during the COVID-19 absence of school, right? Great. So everybody's saying that. So this is where psychosis is tricky, right? So with a young child who is psychotic, right, we often see very bizarre behaviors, right? Kids feeling kind of stuck in those kinds of hallucinations, right? And in older children, it's much easier to identify because around middle school, they start to have that metacognitive capacity and they can sort of tell us that something's wrong. With adolescents often, right, psychosis is more likely to be present, although it's still very, very rare. Adolescents might mask it because, as we know, right, one of the developmental pieces for teens is they don't like to seem weird and they don't like to seem unusual. So we may need to, if a kid is acting bizarrely, we may need to create a lot of safety for them to be able to tell us that this is going on. But again, I want to really highlight the fact that in a child, middle school, teenage population, true psychosis is going to be a rare event. You're going to be much more likely to run into the next item, which is kids with depression, right? So these are struggles with, right? Remember, depression expresses itself very differently in different kids, right? Some kids look really irritable, right? Some kids look overtly sad. Many kids, when they're depressed, lose their motivation, withdraw socially. They exhibit sleep and appetite changes. And sleep and appetite changes can be more or less with depression, right? Oh, there he is. There's Isaac. So we want to think about some of these questions. Does the child seem sad or apathetic, consistently irritable? Has the youth shown a change in activity level or energy? How is the person sleeping, the young person sleeping, and have they withdrawn from engaging with others or activities, right? Many of you, I don't know about folks on the Zoom, but I'm raising kids in the COVID-19 shutdown. I have two 13-year-olds, actually I have twins, and I see some of these signs in them waxing and waning as we move through the shutdown, right? And I think for them, it has to do with sort of struggling with feelings of sadness and loss. But when this becomes a pattern and children are unable to emerge from it and continue to grow and thrive and function, that's when we start to call it depression. So questions about those two items before we move on. Okay. So moving on to anxiety, right? So here's anxiety. I want you to notice how this is different from what we saw in the trauma symptoms. Anxiety are symptoms of excessive fear, worry, avoidance, or panic, right? So that can look like generalized anxiety, a child who is worrying about and fearful of and avoidant of many, many things. It can look like a panic disorder where kids get panicky and very, very stressed and disorganized, right? A panic attack in a child looks very different than a panic attack in an adult. Often a child having a panic attack will seem very disorganized, discombobulated, flustered, but it'll be rooted in some form of worry. And also, right, someone mentioned OCD as a possible place to get confused with some of the trauma symptoms, right? OCD is really a pattern of behavior that is being exhibited that's repetitive and controlling in response to the fear that if that pattern is not exhibited, something will go awry. Notice how easily all of the things I'm describing can overlap with trauma. And you may well find yourself with trauma symptoms diagnosing anxiety as well, because when you sort of pick up the comforter and look underneath it, you'll hear from the child that some of their responses are rooted in definite worry, right? So you ask yourself, is this child acting afraid or worried more than is developmentally or situationally appropriate? Does the child avoid normal activities because of fear or worry? So, right, this can be very tricky to differentiate from trauma-related avoidance, right? So again, we have to be detectives here. I want to talk about the oppositional item, and I actually want to simplify it for you, because often what I see is that folks can confuse oppositional behavior with some of the other things we've talked about. An irritable child is not necessarily always an oppositional child. An anxious child is not always an oppositional child, right? So an oppositional child is a child who actually acts out directly in relationship to compliance related issues, right? This is much more systematically responsive to directives, commands, rules, and expectations than anything else, right? And so you're going to ask yourself, does the child follow rules or directions? Does the child or youth argue with adults when asked to do something? Does the child or young person deliberately do things they've been asked not to do? This item is really rated when we see a distinct pattern between expectations and directives, pushing back, disregarding, challenging. Okay. Josh, I'm sort of breezing through these, so just holler at me if there's anything you want to say. I know you've got a lot going on over there today.
Yeah, no, you're doing fine. Yura did just comment in, I find most parents deny that the child is depressed. They only want them to be anxious. Is the child that is anxious usually depressed?
Well, no, not always, right? It's a great question, Yura. So it's very common, I think, for people to be more comfortable with the idea of anxiety than they are with depression. On the reverse side of it, often anxious kids will tell me, my family, my school, my coaches, they support my anxiety, because when you're anxious, you're more driven to get it right. And it feels more societally acceptable and manageable when a kid is anxious, right? When a kid is depressed, you're not doing the things that you need to do when you're depressed, you're not functioning well, and it's a little more scary in the context of a society that really supports a lot of forward motion. So when parents deny that a child is depressed, it's often rooted in a sense of fear, right? And so it's not always true that an anxious child is also depressed, although it's often true that mood disturbance is correlated, right? So one of the things we want to do is really rely on both the parents and the professionals that are involved with the child, and get a lot of information about functioning before we decide which item to rate. But when we're talking with parents, we can sort of educate them about depression, right? Make sure that they know, don't use the word depression, right? Use some of the words that we had in the last slide, right? So let's go back there. Do you ever see your child feeling sad or sort of bored more than is typical, or really irritated for no good reason, right? Don't even use the word depressed. Monique is saying that sometimes caregivers from some cultures will believe that a child is lazy. I would argue that that generalizes to all of our Western culture, right? That this is something that's often judged and pathologized. So we want to obviously collect information from clinical professionals that are involved with the child, but also we want to talk with caregivers in terms that are not diagnostic and labeling, and then help them understand what that looks like. And often, right, we talked yesterday about the action level language. When we're making it clear that we're doing an action level because we're going to work on it, that can start to feel more reassuring. Josh, do you want to say anything about that? You looked like you were going to say something.
Yeah, and I've just been chatting behind the scenes with somebody about this too, and just wanting to make clear and remind you folks that just what Susie was just kind of saying around the importance of involving the mental health professionals, the behavioral health professionals, the folks that can really help us to make those distinctions and be thoughtful in a clinical manner about what is depression, what is anxiety, right? And that's one of the great powerful pieces of these tools is the capacity we have to access everyone, right? I know I mentioned, I can't remember if it was AM or PM yesterday, but I mentioned the way that I really look at this is the community's assessment, right? It's not your assessment, it's not the kids, it's not the family, it's the community of practice, the community of people who support and love the child that we're serving. And so involving those folks who have that clinical knowledge and can help us to really make those distinctions is critical. And then also working with those folks to help explain that to the caregivers, right? And to the children themselves to help them understand. We know that you're calling it anxiety, but here's why professionally and clinically we might see this as depression, and helping those folks to understand the differences and really do that teaching with them, right? That's a part of our job too, is to be teachers and to help take some of that deeper knowledge that we bring about certain topics to the family, and then listen to them bring that much deeper knowledge that they have about their own family and their own needs back to us, and really have that collaboration.
Right. And it's well said, Josh. And Carolyn is sort of adding to that conversation. She's saying so many of these diagnoses often seem to be intertwined and not easily separated. And then if you add a developmental disability, that confuses things too. And what the whole approach behind TCOM is really what Josh has been describing to us, which is, right, in a traditional treatment approach, everybody looks at the information and assigns their own idea, right? And so when something is complicated, right, and this system of services is designed to meet high need kids' issues, right? So when something is complicated, right, that happens more to a kid and a family. And what inadvertently we do is we assign labels, we interpret through our lens, and then we apply disjointed, disconnected services that reduce the effectiveness overall. So the TCOM approach here is that when it gets like that, Carolyn, and that's well said, intertwined and not easily separated and confusing, we do what Josh is talking about and rely heavily on building consensus amongst a team so that we start to focus in on what really needs to be changed in the life of a child to help them develop on track, right, and thrive. So the TCOM approach is markedly different here. It really encourages you to rely heavily on all of the sources of information and work to bring them together, both in your action level rating and in your plan of care. Great question. Great questions. So let's finish up with some of these behavioral health items, and then we'll look at an example. So conduct disorder, right? I want to remind you that this is an item that is checked in older children only. And this is different than oppositional behavior, right? So you don't rate a kid conduct disorder because he's irritable or because he pushes back on his parents, right? That's not a conduct disorder. A conduct disorder is a very significant pattern of behavior of violating the rights of others and the law, or the law, right? So you're looking at a child who acts dishonestly, again, taking developmental issues into account, right? 5-year-olds, they love to lie, right? Now, it's different than lying for a 5-year-old, right? It's making stuff up and seeing how their reality matches the reality of their parents and sort of checking out what they believe to be true. They're not seeing it as lying, right? Acting dishonestly is a child who's directly lying, right, to people in a known way, right? Does the child break the law? Has the child hurt or tried to hurt other people? Again, this is injuring animals or people in a non-reactive way, right? This is not a kid who's dysregulated and lashes out when they're upset, but this is a child who's more planfully trying to or planning to hurt others, right? And does the child show a lack of concern for the feelings of others? So again, it's really important to focus in on that pattern piece, right? The next item is about emotional control. Now think about this, right? This item also, right, is another one of those things that's overlapping and intertwining with that dysregulation item on the trauma symptoms module. Sometimes we might rate both, right? So what this looks like is, right, challenges with managing emotional reactions, right? this often coexists with other diagnostic issues, right? So often a child who has trauma symptoms will have challenges managing strong emotions, right? Often a child with anxiety or an irritable presentation of depression will have difficulty managing strong emotions, okay? And so it's looking at when the child has emotional reactions, are they larger than life? And does the child need a lot of support to come back to baseline? And does the child or youth tantrum more than is developmentally appropriate? And remember, we talked about that example yesterday with Roberto, who is 3 years old and is having a tantrum. The frequency is pretty normal. The kicking is a problem, right? So with emotional control, we're looking at a child who tantrums and can't be calmed, for example. If they're 2 or 3 years old, it takes them a really long time to calm down. Or a child who has a really strong reaction to something and can't manage it in an adaptive way. The next item on the behavioral health module is the attachment item. This one is often something that can be challenging to rate. This is difficulties with relational behaviors, but we don't want to think of this as social skills, right? Those are actually different. The capacity of a child to interact successfully with other people, to have the skills of eye contact and making conversation and responding in conversation and being considerate, all of those things that kids have to learn to develop. Attachment is more specific with that than that. This has to do with placing significant attachment relationships in their proper spot and being able to engage in them in an adaptive way. So it can look like a kid who struggles with separation, right? Again, developmentally appropriate struggles with separation, right? If we walked over to Josh's house and tried to take Esri and hold her right now, she might have something to say about that, right? But I remember meeting Esri, I don't know, Josh, it was probably 9 months ago. We had a hamburger together in Rochester and she was fine with me picking her up and holding her, right? And that'll wax and wane throughout the next few years of her life. And that's really appropriate. This has to do more with a kid who really gets distressed, gets preoccupied with separation, and cannot sort of calm themselves and move into a safe environment to explore. The other way this can present is a child who's undifferentiated from an attachment perspective, right? This is a child who is inappropriately, intimately relational with strangers, right? Forms bonds with new people too quickly, right? So this is very different than sort of anxiety. This is very different than poor social skills. This has a distinct way of thinking about it, and it's helpful to think about those important relationships. Does the child struggle with disengaging from them, or does the child try to form them with people in an inappropriate way? So we're going to, excuse me, we're going to look at an example now. This is Jay.
I can read this one.
Yeah, go. Thanks, Josh.
So Jay is 15 and has just admitted to his family that he's been smoking weed every day and is taking his aunt's lorazepam almost every day for the past 2 weeks. Jay says that he's been feeling frightened and anxious, afraid and panicky, and that the weed and pills help him to sleep and stay calm. A few weeks ago, before he started using, he was unable to sleep for several nights in a row and could not concentrate on his schoolwork. The next morning, he slept through his alarm clock, missed an entire morning of virtual school. Jay says he's also tried to burn himself with a match, and last week, to try to calm down, a friend of his told him this might help him. So again, we kind of gave you some of the color coding here to help guide you, but now's a good time. Go ahead and chat in. What are some of those behavioral health items that we are seeing here that we might need to be thinking about rating for action or gathering more information about?
Great. Anxiety. Josh, you can take this one if you've got the quiet and the calm. Go for it.
Sure, for the moment. Yeah, so we're seeing anxiety. Rebecca chatted in about self-harm. Curious to hear a bit more about that. Self-injury, right? Self-injurious behavior is sort of the way that we refer to that. Dependence on the drugs, right? Which is not necessarily one of our behavioral health items, but something that we are thinking about elsewhere, right? Could be anxiety and depression. What is going on in his life? Good. So Yura's thinking about, I need to gather some more information. I'm seeing some signs here, but wanting to gather more information in order to really make a decision on that. Also chat in, who would you speak to? And obviously we're not giving you much information about Jay at this point and who he may or may not know, but I'm curious to know, for those of you that are kind of saying what's going on in his life, what do I need to learn? Who would you learn that from? Chat in real quick with a few of your thoughts around that. Who would you be wanting to speak to? I'm seeing aunt, the parents, guidance counselor is a great example, right? Therapist, aunt again, Jay himself, thank you, Catherine, a social worker, if he's involved with a social worker, either through school or potentially already connected to an HCBS service or to other services in the community that would put him and give us access to that. Teachers, right? You know, something that we're seeing a lot right now in the age of COVID is teachers, school social workers, school counselors, all those folks are getting really an unprecedented peek into the family life of their kids that they serve, right? Some teachers, you know, have kind of developed those relationships and learned, or maybe live in the same community as their kids, so they get to learn a lot about them. But in many cases, teachers don't always have that access, and suddenly they do, right? They're in your living room. My son's teacher was just in our kitchen, right? And so those folks are getting peeks into more kind of angles and more of the rounded picture of who their students are, maybe than they ever had even when they were in person in front of those kids. And so those are really important people for us to be accessing and learning and gathering information from, and certainly all the mental health professionals and behavioral health supports that are out there. So great, thank you to you all for that. Go ahead, Susan.
Thanks, Josh. So let's move on to, right, remember we talked at the very beginning of this review of the SED level of care determination. We talked about how it's unique in that we draw a little bit from the caregiver strengths and needs domain, right? When we're thinking about these ratings, we're thinking about, remember that issue of interfering with functioning? It's very specific when we look at the caregiver strengths and needs domain. We are looking at the caregiver's capacity to parent the target child, right? And so when we're thinking about rating actionable needs here, the functioning question we're asking ourselves is, does the caregiver's decision-making, stress level, care and treatment involvement impact the caregiver's capacity to parent the target child? Right? So that's part of it. And remember, the other piece is action. Does the caregiver endorse this issue as a need? Do we need to take action? Is action required to shore up the functioning, the capacity of the parent? Okay, so we're going to look at the items from the caregiver strengths and needs domain that feed into the level of care determination. And there are just 3 of them, but they're very important. The first one is decision making. It's the caregiver's ability to understand and anticipate the impact of decisions and the ability to decide upon a course of action and self-regulate behavior. Right? So questions to think about: does the caregiver think through problems and decisions, right? So some of the parenting problems and decisions that would be involved here would be, how does the caregiver choose to respond to the child around the child's behavioral needs, right? How does the caregiver choose to prioritize the resources and actions in their world to support the target child? Do those decisions exhibit a showing of good judgment? Lois, I'm gonna come back to you in just a second. Let me just finish my train of thought, because if I don't, I'll lose it. But that's a great question, and I'm gonna come back to you. Does the caregiver show any challenges with judgment that interfere with parenting? This item is often rated when we see the presence of, one example can be multi-generational trauma, right? So caregivers with their own trauma histories can struggle with keeping their wits about them around decision-making when they're being triggered by the events going on in their world. Caregivers who are struggling with substance use and abuse challenges can often show correlate challenges with judgment and decision making, but there also could be issues associated with the caregiver's developmental delays, right? So again, this is not a value judgment. This is saying that caregiver can use some external support with decision making to shore up their capacity to parent that target child. So I want to back up. Lois has just put in a question from a few slides ago, and she's asking, how do we rate a child when the caregiver says the child is responding to treatment? It's a great question. And it brings us back to that communometric set of ideas and principles, right? So first of all, it depends. John Lyons, who's the founder of the TCOM approach, says that all the time, and it drives people crazy. But the root of the approach is that we want to think about what the caregiver is saying, and we want to think about all of that information from other providers, from the child, and from the community, right? So how we rate is step 2. How we respond and build consensus is step 1, okay? So let's think about that. If a caregiver says a child is responding to treatment, my first question is going to be, tell me more. What changes do you see, right? What improvements do you see? How is this need shifting in your eyes, okay? And then I want to validate that, and then I want to try and build consensus with the other information. Now we're going to put some consensus building strategies into tomorrow's webinar, because a lot of folks are asking questions about consensus building strategies. But then I would move to, once I validate and hear all of the ways the caregiver sees responsiveness to treatment, then I would say, okay, so let's go back to our shared vision. Let's go back to this idea that we want to make sure your child stays out of placement, right? Or let's go back to, we want to make sure your child is thriving at home and in school, whatever the goals are, right? Now let's look at what still needs to shift and change, and how are we going to focus on that? And then I would bring in information from other sources in the context of that collaborative conversation. And Josh, I want to just lob that over to you. Anything you want to add to that?
Yeah, I think the other kind of critical question that I would ask, right, and I would start with that caregiver who says the child is responding to treatment. I would say, what happens if the treatment is all done tomorrow, right? And I would say, what do you think will happen? And not as a challenge, but as a true question around, is that treatment at this point resolving the child's need, or is it masking it, right? And if the response is, I think this treatment has helped, I think my child has all the skills necessary to deal with this on their own, then that probably is telling me what my answer is, right? Or if they say, gosh, I think I'd see a pretty quick regression back to the old behaviors, the old needs, then that's also telling me, right, that we're maybe not there yet, we're maybe not to resolution. I would also ask that same question of the person delivering that treatment. If it's, I assume the question was sort of meant around some of the behavioral health stuff, since that's what we were just talking about. So I would ask the therapist, right, what do you think would happen if we were done with this and we were setting little Joey free, right, to sort of be without you at this point? What do you think would happen? And I would really try to explore that with everyone, including with the child themselves, if they're of an age where they can have that conversation with us. And that would help us to really identify, are we on our way to resolution, in which case we're probably still masking the needs, or are we there?
Great. And great minds think alike, right? Monique is chatting in, what if treatment is removed, right? That's it. That's the question. What if a child loses Medicaid, right? Ask those kinds of questions, and that really helps clarify what needs to happen next. Great. So let's move on in this domain, the caregiver strengths and needs domain. We're going to talk about parenting stress. This is an item that's dear to my heart. Many years ago, I worked with a researcher who actually identified parenting stress as a critical component to parenting outcomes. He was one of my mentors and teachers at graduate school. And this was, it's going on 30 years ago now, when we figured out that stress was a lot like pain, which you nurses know so well, right? That pain is experienced very differently by different people. Parenting stress is the same way. Three parents can experience the same situation around parenting as very different levels of stressful, right? And what we now know is that the level of experienced stress is an independent predictor of parenting outcomes. And that's why we want to take a look at it and we want to address it if it's there, right? So we're looking at the degree of stress or burden that the caregiver experiences as a result of the demands of caregiving and parenting, right? So this can look very differently. We want to think about, talk about, ask about, read about in our record reviews. Can the caregiver manage the stress of meeting her or his children's needs? And does the caregiver report or express stress that's interfering with coping and parenting? Interestingly, a lot of times when we see parents first start thinking about their stress level, they'll say things to us like, I can't manage anymore. I want to place this child. I've had enough of her, him, right? And we often see this as a disconnect from the commitment of the parent to the child. And actually, it's often a sign that the parent feels they've tried everything, they're at their wits' end, and they're so stressed out that they can't respond anymore. So when we start to hear those signals from parents, we really want to sort of be detectives about parenting stress, you know? And the other piece to think about too is this can look like evidence, but it also can look like the caregiver endorsing that need, right? We don't need to make a judgment. It's not a value judgment. What we know is that if I tell you I'm a 3 on parenting stress and I cannot manage my child right now, we know from the research that that's just like saying I'm a 10 on pain. We providers don't necessarily get to decide that you should be a 6 on pain, right? It's the same with parenting stress. The next item is care and treatment involvement. This is the last item from this domain that feeds into the level of care determination. And it sure makes a lot of sense, right? That the caregiver's ability and willingness to be an active participant in the child's care and advocate for their child is a really important piece of success in the community when a child has serious emotional difficulties, right? So interestingly, I have a buddy who's Nancy Craig, who's one of the lead family advocates in the state, and she talks a lot about how parents' capacity to care for a child with a serious emotional disturbance often shifts when you teach them advocacy skills, right? And so we want to think about how involved is the caregiver in the plan development? Does the caregiver want help to become more effective or involved in delivery? And is the caregiver an effective advocate? Please notice here that we are not judging the caregiver. We are not pathologizing the caregiver. We are looking at whether or not the caregiver could benefit from external support around these skills and abilities, okay? We're just going to take a look at an example before we take a 10-minute break. And here's back to Ginny, right? So remember, Ginny is that youngster who's 8 years old, who has that abuse and neglect history, right? And her dad, right, is part of her new family, and she's having trouble building a strong relationship with him. She's avoiding him, right? When she is asked to come to the table for dinner, for family meals, she refuses and becomes rageful. And her father says he's finding it really difficult to build that connection with her, and her unpredictable outbursts of irritability and anger are impossible to handle. He says he's not sleeping because his stress around parenting Jenny. So what do we see here? Just call out of those 3 items we just talked about. What are you seeing evidence for here? Chat out, sorry. Call out or chat out. Definitely parenting stress, right? And interestingly, right, this is a common finding when kids are transitioning into their families in an adoption process, right? We want to make sure that when kids have difficult histories and parenting is that much more challenging, that we make sure that parents have adequate support to manage, have strategies, right? Manage their own stress and have strategies to respond to those challenging emotional transitions. So we're still working our way through those domain items that contribute to the SED level of care eligibility. So we're going to look now at the items that we pull from the child strengths domain. couple of important things to remember here, right? First of all, the child strengths ratings are reversed, right? So actionable strengths are those that are either not identified or useful, right? Twos or threes. Remember that sort of birthday cake diagram we showed you yesterday, right? And also important to understand is the reason these items are there is that the domain is about looking at assets that support health development and well-being, right? We know there's a lot of research now too that's telling us that asset-driven treatment for kids with challenges around behavioral health and trauma is really more powerful than pathology-driven treatment. And so we want people thinking about strengths. But why does it feed into the eligibility determination? Well, because we see sometimes when we look at the difference between kids who are high risk for placement and particularly long-term placement, what we sometimes see, or what we actually often see, is that the difference between those two groups of kids, kids who survive and thrive in their communities and kids who struggle and repeatedly are placed or stay in institutions, it seems to be that the presence and absence of strengths is one of the differentiating qualities of those two groups of kids. So we're looking at this, right? When we get into those twos and threes on these strengths, it pushes kids up into a higher risk of placement group. So there are two key items that we're looking at from the child strengths domain when we're looking at HCBS eligibility. And those are the child's social relationships with adults and the child's relationship stability. I want to focus in on these a little bit. As you know, I've done some case reviews from the CS population, and what I often see is a misunderstanding of what these two items are getting at, particularly the second one. But let's start with social relationships with adults. When we're looking at strengths, right, we're looking at whether or not the child has social relationships with adults outside of the family that are high quality and useful to the child, okay? So I wanna check in with you, right? You probably remember from our introductory, our CAN certification training, that we talked about the usefulness of strengths quite a lot. So when we use that word useful, we wanna really understand what that means. A useful strength is a strength that I can actively draw from to support healthy development and well-being. Right? So when we're looking at, for example, a lot of us are working with our own kids and kids who we work with professionally who are struggling with the COVID-19 shutdown, right? One of the reasons is that some of the relationships with adults outside of your family, particularly for older kids, right? When you start to get annoyed at your parents, which is a developmentally appropriate response for a middle schooler or a teenager, right? Often we know that kids who have tribes of adults that they can connect to outside of their family, their immediate family, do better because they can start to maintain some support with guiding connected adults. And so kids are sort of cut off from things like teachers and coaches, right? People who they build different kinds of relationships with. Useful means I draw from that relationship to support healthy development and well-being. I'm able to interact with that person socially. They are connected to and invested in me. I feel close and connected to them in a way that supports my mastery, my competence, my healthy development, right? That's what we're looking for with that item. The second item, I would want to call everybody's attention to this item. Relationship stability, right, is a specific item looking at a specific strength. I'm going to give you a little context here. We're starting to see in the research that one of the predictors of poor outcomes for youth in the social service mental health systems, one of the poorer outcomes is related to the more times a child changes their attachment relationships, right? So kids who lose important people early in life, kids who are repeatedly shifted from foster home to foster home, right? Kids who don't have that tether of significant relationships in and outside of the family, okay? This is not about poor social skills. This is not about my relationships are rocking and rolling because I don't have social skills, right? We're looking at those issues in those social relationships items, okay? What we're looking at here is, do I have stable, lifelong experiences with significant people in my life, right? This is actually not about my social skills as the youth being rated, but about my contact with my parents, my relationships with adults that have lasted their entire lifetime. Many of you are too young to remember the early days in residential care where I started my career. And we used to be told the best thing for a child is that when they get transferred to another facility, you just want to cut off contact because you want them to be able to successfully attach to the new caregivers in the new residential system. Well, it turns out we were all dead wrong about that. That ongoing stable connections and attachments simply serve to support the child's ability to make more ongoing connections and attachments. So just to be clear here, what we're rating is the child's experience of relational stability, okay? Let's look at an example. So here's Ginny again, right? We're talking about Ginny. She was 8. She has a history of severe abuse, a significant abuse and neglect, but she was adopted by her family last year when she was 7. Okay, so she's had difficulty building a strong relationship with her father. We know this. We've talked about this in other slides, raging and avoiding him and telling her therapist that he reminds her of her abuser. She doesn't want to be around him, and she's avoidant of any other male adult. Ginny's teachers say she frequently spaces out at school, right? We talked about that earlier. But also her teachers say it's very difficult to build a relationship with her because of her detachment. So what do you think? What are you thinking about those two items? Would you be tempted to rate? So if you can just chat in yes or no. Let's start with social relationships with adults. Are we thinking that Ginny might have challenges with connecting with some adults and having consistent social interaction that's supportive of her development? Yeah, right. So everybody's definitely says, yeah, definite challenges, right? So yeah, yes, for sure, right? So here we see that important strength that we just talked about, right? We'd be thinking about a rating there. Let's move to that second one. Do we have some, at least a little bit of information here that talks about the fact that Ginny may have had some disrupted early relationships? That's that relationship stability item. Yeah, where's that coming from? Where's the evidence there? What do we know about Ginny's history so far that tells us that that might be an issue for her? She was adopted, right? And she was adopted at what age? She was adopted at age 7. Okay, so it's really important to understand, right? Yes, she was abused and adopted. So we are going to start looking through the records to see, right, what were Ginny's first 7 years like? How many relationships did she lose? How many placements did she have, right? And we're going to be looking at that 2 and 3, okay? Now notice I put this information in deliberately that Ginny is 8 and was adopted last year. This is very different than a kid who's adopted in infancy, right? A child who's adopted in infancy is not experiencing relationship disruption, right? They're adopted into their family. Their parents are their parents from the time they're an infant. And so it isn't experienced in the same way. So adoption is not an immediate rating for relationship stability. Okay, good. All right. So now we're going to move on. We're still in that domain side. Remember, we talked about the sort of more symptom-like ratings on the module side, and then looking at functioning on the domain side and how those two things work together to determine level of care eligibility. So the needs and functioning domain, we're going to pull a few items from that domain for eligibility, just a few. And again, the domain itself is a broad look at how the child or young person is functioning in a variety of key areas. But for the determination for eligibility for HCBS, we look at, remember, we talked about items that tend to be connected with a higher risk of placement. Okay, and the 2 items from that domain are the child's living situation and the child's decision making and judgment. So let's start with living situation. Really, really important. This domain and this item is about how the child is functioning in the living arrangement. Does that make sense? It's not about how the caregivers are functioning. It's not about how the caregivers, what their external supports they require are. And it's not about the quality of the external environment, right? So this is where the child's head hits the pillow, right? That could be a foster home, that could be their family home, that could be a long-term residential placement, or right? This is how is the child behaving in that setting, right? How is the young person getting along with others? Now, sometimes the clues that there's an issue here come from the responses of the caregivers in that setting, right? But this is really about how the child is functioning. Often when we see misunderstandings about we see people rate what they perceive to be the quality of the caregiving context. This domain in this item is about how the child is functioning. Why? Because a child who is functioning in ways that challenge their context is more likely to be placed, right? And so when caregivers start to say, we cannot manage him, he's acting out all the time, he's putting his siblings at risk, we don't know how to handle it, we're thinking about placing him, those are some clues that it might be an issue with this item, okay? The next one is also, right, we talked about this one for the caregiver. Here we're rating the child's ability to understand and anticipate the impact of decisions, right? And the ability to decide a course of action or self-regulate. Now, really important here, remember that key characteristic of taking development into account. Kids have an ability to think through problems and decisions at an age-appropriate level, right? And interestingly, right, and I'm in the middle of this now, right, we all know that there's sort of an early childhood version of thinking things through and controlling and deciding on a course of action. And then kids get a little better at it when they're 8, 9, 10, 11, 12. And then we see another sort of neurodevelopmental storm that starts to make kids look a little cloudy in their judgment. So we're taking normal development into account, but we're looking at how the child's decisions impact their day-to-day health and well-being. So again, let's look at an example. And we're back to Jay again, right? So Jay is 15, and remember, he has just told his family he's been smoking weed and taking his aunt's lorazepam every day for 2 weeks. He's been anxious and frightened and panicky, and the substances help him sleep and they help him be calm. A few weeks ago, before he started using, he wasn't able to sleep for several nights in a row, and he couldn't concentrate on his schoolwork. And the next morning, he slept through the alarm clock and missed his virtual school. Jay also says he tried to burn himself to calm down. A friend of his said that it might help him. So what do we know right now about Jay's living situation, about how he's functioning in it? So Brianna says he's comfortable telling his family about his drug use, right? So that's a little hint, right? It's not yet enough to rate, but that's a hint that it's not necessarily, right, his functioning in the living situation is not necessarily, right, a problem for the caregivers, that there's some kind of connection there, right? He has a good comfort level with his family. So do we have evidence that he's behaving in ways that are really putting him at risk of placement vis-a-vis his living situation right now? No, right? No, folks are chatting and no. So, right? But now let's go to his decision making. Do we have any evidence that his decisions about how to manage his anxiety, his judgment about that, could use a little external support? Yes, right? So Monique is saying his decision making seems poor. His judgment is poor, right? Burning yourself with a match is probably not the best way to go. Stealing your aunt's lorazepam, right? So we do have some sets that we might want to sort of dig a little more into that, talk with other providers, get a little information about that. Now, the other piece that I want to sort of point out here is that this story, Jay's story, really points up that conversation we've been having all through these 2 webinars about you have your HCBS eligibility items, you got to get enough information to rate them, but in the course of trying to rate them, you're learning about a young person and you're learning what more you need to know. So here we might rate his decision making, but what do we know about the root of his poor decision making? which wouldn't be rated for an eligibility determination. We know that he's terribly anxious, and we know that he's using substances to manage that, right? So that means, right, that again, when we start to get to the planning of our coordination of care side of things, we have all this good context about what it is we're going to be targeting. So given what you know about Jay, what are you thinking is a core target need that we'd want to look at for him? And we want to make sure he's got supportive services around. Yeah, so Heather wants to know what's the cause of his fear and anxiety. His fear and anxiety is really one, yeah, depression, you're saying, might be an issue. Why is he afraid? Might be an issue, right? We might want to step back and think about the fact that a lot of kids with just biologically inherited anxious temperaments are experiencing a lot more anxiety in the current environment, right? We've had two pretty big developmental insults for kids. If Jay is right, he's locked down at home, his whole world has changed, right? If Jay is a child of color, right, there might be another set of reasons why he's feeling particularly stressed and frightened right now. And so we want to really make sure that we're getting information about that and supporting services for that as we move into that plan of care stage. So again, right, we're talking about functioning and whether or not some of the child's challenges interfere with functioning. So we're looking at two important pieces of the school domain, right? We're looking at how the child is behaving in school and whether or not the child is going to school, okay? So the first one is quite simply, is the child behaving in school? Has the child had formal disciplinary actions taken against him or her? And has there been a referral to an alternative educational placement, right? So a child who has been expelled, right, or suspended, right, that would probably be a 3 if the child is currently expelled or suspended. School attendance is different. This is whether or not the child is able to get to school and whether or not the child is on time for school, right? How many absences has the child had? Is the child on time? Does the child stay for the entire day, right? And we know that a lot of times kids are challenged to get to school and stay at school because they have attendance, psychiatric challenges, or trauma symptoms that are not well managed. And so we're looking at functioning here. So let's look at Ginny again as an example, right? This is a story we know, but we get a little more information from her teachers down at the bottom, right? So Ginny's teachers have told us before about her attention challenges and some sense of detachment, but we also hear that Ginny has tantrums several times in the classroom, that she reacts when she's asked to focus on her lessons. And Ginny's parents have now been called in to meet the child's study team. So do we have some evidence that her behavior is of concern in the school environment now? Are we thinking about that school behavior item? Right, folks are texting in, yes. What about attendance, gang? Do we have any evidence to suggest that she has any problems with showing up at school on time and being in school every day? Folks are taking a minute to read through. Remember the vignette assumption, underline the evidence. We have a lot of evidence about her functioning in school, but do we have any evidence? Right, so Heather says nothing so far, right? No attendance issues so far. I love that so far. We're not going to rate that because it's not happening. But we all know that if we don't move in and give this youngster some support, it could generate problems with attendance later on. Well done. Okay. So the risk behaviors domain is very straightforward. I love the way John Lyons describes this. He always says, these items are behaviors that could get the child or someone else hurt or could get the child in trouble, right? And so those are the questions you want to consider and ways to talk about it with the kid and the family, right? It can feel very intrusive to come up to a parent and say, has your child ever participated in sexually reactive behavior, right? We don't want to use these terms when we're talking with a family, right? But we want to look at the records and we want to talk to providers and we want to ask kids and families, right? Sometimes kids do things that get them into trouble. Anything like that happening in your child's world, in your world, right? Sometimes kids do things that people think could get them hurt, right? Anybody yelling at you about anything like that. Okay. And so just going through these items quickly, I want to make sure that you understand how to differentiate the items because some of them have similar names, but they are very different. Suicide risk is straightforward, right? This is an ideation, attempts, intent, right? These are the classic issues with suicide risk. Self-injury is different, as you all know, right? This is not necessarily suicide attempt, but attempts to injure oneself as a self-soothing mechanism. Just incidentally, it's really good to know that we used to think of these two things as very uncorrelated, but now we know that although we need to treat them differently, they are actually correlated, that young people who self-injure are at higher risk for suicide. So we don't want to think of self-injury as an attention-seeking behavior. We want to think of it as a coping behavior that is helping a kid manage unmanageable emotions, which ultimately could increase their risk for suicide, right? Other self-harm is an item that people often get confused about. We like to talk about this in terms of recklessness. So this is the young person who does something that puts themselves at risk and or puts others at risk, but it's non-intentional, right? So some of the examples that I like to give are the condom challenge, which is a recent one I heard about, where kids are breathing a condom into one nose and out the other and trying to blow a bubble, right? They're learning how to do it on YouTube. And several kids across the country have asphyxiated trying to do this. Other more typical risky behaviors for teenagers might fall in here, right? Drag racing cars, those kinds of things. Danger to others is distinct from that. When we talk about someone being dangerous to others, this has that intentional component to it, right? So these are kids who are wanting to, planning to, or hurting others when they're angry. Recklessness is other self-harm. Unintentional risk. Danger to others is volitional and intentional. Okay, even if it's transient and impulsive, it's volitional and intentional. Fire setting is the classic risk symptom of setting fires, even small ones. Now, the next two items are similarly named, but we want to make sure you understand the difference. Sexually reactive behavior and sexual aggression are very different. We had an example yesterday, if you remember Tammy. She had sort of two different kinds of behavior. Sexually reactive behavior is developmentally inappropriate sexualized behavior that is often rooted in some sort of inappropriate exposure, right? And that can be certainly sexual abuse. It also can be witnessing sexual activity or witnessing pornography. In contrast, sexual aggression is perpetrating sexual acts on someone by using some kind of a power differential. Okay, those are two very different behavior sets, and they're two very different treatments for those. And so it's important to know the difference when you're looking through records and talking to professionals. Okay, delinquent behavior, it's linked to that conduct conversation we had earlier in today's webinar. Those are behaviors that are violating the law. The bullying item here is when a child is bullying others, right? This is not when a child is being bullied. We do want to think about that because being bullied can put kids at risk for all sorts of things. But here we're rating when the child is doing the bullying. Runaway is just that, kids who are running away. And I want to just cite an example that I saw from the case reviews, right? A child who is attempting to run away repeatedly, every time that the parents set a limit, and who is physically stopped at the door and doesn't make it out of the house, should still be rated on the runaway item. The runaway item is about running away. It's not about how far they get, okay? Because if a child is using that kind of escape behavior, we need to really intervene around it. Here's the single most misunderstood item on the risk behaviors domain, okay? Problematic social behavior. Catherine, I'm going to come right back to you in just a second. Well, actually, I want to answer that question. It's a really good question. Do siblings count as people the child could bully? Yes, siblings count. However, really remember that you have to take normal sibling interaction into account, okay? Because kids can be really hard on each other and with each other, right? So bullying is a systematic pattern of threatening, frightening, intimidating, and sometimes hurting other people, right? So that's what you're looking for with bullying. Um, Yura is asking a really, Yura, let me read through your question. It's an important question, and I don't want to. So Yura is asking, what are some of the things we could tell parents now with the child being home? Because all of kids are pretty much isolated at home, and a child from my daughter's high school just committed suicide. I'm very sorry to hear that. That's really tough, and wishing you and your daughter a lot of support. What I'd like to recommend for you is two things. First of all, I'm going to try and talk a little bit about that in tomorrow's webinar as part of the Q&A. But the other is that we have done, there are two resources for you that I can put up tomorrow. One is that we did a webinar on how to work virtually with families and kids, and that is available on the CANS Institute website and gives a lot of strategies. But the other is that I did a webinar for CTAC, and I can put that, I'll put that up maybe in the Q&A tomorrow on some of the strategies you can use with families now that kids are home. So that's a really great question. It's very complicated, and we're gonna try and get some content to you and your team around that question. Okay, we'll set you up with that. So coming back to the risk behaviors domain, the problematic social behavior item is the one that is most frequently misunderstood, okay? Problematic social behavior is behavior that is risky or inappropriate and is being done to get attention or get an outcome to happen. So let me give you an example. If a child is significantly disabled around learning and unable to get the support that they need, and they begin to develop a pattern of blowing out of their classroom by swearing at the teacher, acting like a goofball, right? Being inappropriate in order to mask, right? Being found out, right? Because if the teacher calls on them in front of their friends and they don't know the answer, they get made fun of. That child is exhibiting problematic social behavior, right? So we're not saying the child is exhibiting behaviors that the social environment doesn't like, or that the child is awkward socially. That would be rated under social skills. What we're saying here is the child is acting out in some way in order to meet some kind of a goal. It's maladaptive acting out, okay? So this is one of the most highly rated items across the state on the CANS, and including for the folks in HCBS, and it's one of the most misunderstood. And finally, eating disturbance is any disturbance with getting food into the body that puts the child at risk. Certainly disordered eating behaviors like withholding calories, controlling calories, and binging and purging would be here. Significant overeating that puts a child at risk, right? That could be here as well. Okay. So just as we've done all along, we're going to take another look at one of the two stories we're sort of tracking along these items. Let's come back to Jay, right? So we're looking here, what are the risk behaviors we see for Jay? And you have a pretty easy, clue. So what do we see? What's Jay exhibiting that would be actionable on the risk domain? Exactly, right? Self-harm. This is also, right, important to think about the what, not the why. We know he's doing this for a reason, right? He's anxious, right? And he's trying to find ways to manage his anxiety. But the what here is that self-injury is something we want to rate and make sure that he gets support for. Good. So before we move on to the medically fragile determination, I want to cover one other really important concept with you. there's sort of three concepts that can really help you hone in on the ratings for the HCBS determination. And we talked about two of them at length yesterday. Remember, we said sort of break up your thinking into function and action. How much is this interfering with the child's functioning? And what is the action level required for support, right? Well, there's a third concept I want to throw at you today, and that is this concept of action overriding anchor. Okay, what do I mean by that? Well, when you open your CANS items and you look at how they're described, right? They're described in a pretty traditional structure, right? Whether you have them in an HCBS rating tool or in the UAS system, they kind of look maybe a little different, but it's the basic structure that you see here. First, you see an item name and an item description. Whoop, how that happened. So the item name and the item description are really important for you to understand. We've talked a lot today about these subtle differences in that item description, which is telling you, what's this item getting at, right? I don't want to just go on the item name. I want to understand what the item is meaning to measure or look at, right? So here we're looking at that care treatment involvement item from the caregiver strengths and needs domain. And it tells us the description. We're looking here at to what degree is the caregiver involved in seeking and supporting care and treatment to address the needs of the target child, okay? Really important. We don't want you throwing that out. We want you to know that description and don't assign ratings to something just based on the item name. However, when you move down and you see the action levels here, 0, 1, 2, and 3 on the left-hand side, and then the anchor language, we call it in the TCOM world, this is the description of what would be a typical 0 for this item, a typical 1, 2, or 3. People often get hung up here in this anchor language. The language is there to anchor you in what a typical action level might look like for this item, but it is not there to tie your hands, right? Because we couldn't possibly thoroughly explain every example of a typical 0, 1, 2, or 3 for every item because of the wonderful complexity of the people we serve. We're going to have examples that work here, that don't fit in here. So let's think about that. Let's take a look at a 3. The caregiver does not wish to participate in services or interventions intended to assist the child. The caregiver's lapse in treatment involvement and consistently places the child at risk. So if we hung on to this anchor language, this does not wish to, and this caregiver lapse language, right? Then we might miss a caregiver who, for example, a caregiver who's just received a catastrophic medical diagnosis of her own might be unwilling, right, to participate in treatment or unable because of needing to manage her own emotional and physical needs, right? A caregiver who's been hospitalized, a caregiver who is involved in a significantly toxic domestic violent relationship and is unable to organize herself for that reason. There are lots of other 3s that we might throw in here, but if we get really hung up on the anchor language, we might miss those 3s. So what we'd like you to think about and walk away with is this little hint: action overrides anchor. When you're in doubt, when your example does not fit, go back to what we talked about in yesterday's webinar. What is the level of action called for? Do we need to do something right away? So for example, if a caregiver has postpartum depression and is unable to care for her children actively, right, we would probably move in and try and pull in some informal supports to take over the care of those children. We're not going to wait for 3 months to do that, right? That would call for a 3, even though it has nothing to do with the caregiver's wish to participate at the present time. Josh, anything you want to add to this? No?
No, I think you got it.
It's a really important concept. Okay, so we're going to move on now, and we're going to dig into that, the next eligibility determination for HCBS, and that's that for the medically fragile youth, right? So this one is a little bit simpler, right? And as we talked about, right, we're really looking here at the needs that are present that reflect the functional and systemic impact of the child's medical diagnosis, okay? So we're looking at how does the medical diagnosis, the needs and treatment associated with that impact day-to-day functioning. And I just have to say that I love this picture. I get a real kick out of this picture. This kid is adorable. Okay, so we're going to start with that extension module, the medical health module. I have to say that in all my work and looking at the data and working with case reviews, I think the two most poorly understood and most challenging to rate modules are the trauma symptoms and the medical health module. Here we're not talking necessarily about the medical needs themselves, what's the diagnosis, what's the medication, but we're talking about sort of the bigger picture impact of the medical diagnoses and needs on the child's functioning, right? So when we're looking at the medical health module, we're looking at two items that are really important on that module, right? We're looking at, four items. I misspoke. First, we're looking at life-threatening, right? So this is there a risk of death associated with the child's current medical needs, right? If the answer is yes, then we need to sort of look at differentiating between a 2 or a 3 or a 1, right? Let's look at how often is the child in the ER, right? How long are the hospital admissions, right? And as we saw yesterday in some of the examples, does the diagnosis involve a shortened lifespan, right? And I think Gus said something about, right, that sometimes most kids can beat a diagnosis, right? And so, or not most kids, some kids can beat even the most dire diagnosis, right? So we're really looking at what is the proven prognosis, right? What's the likelihood that the child's life will be shortened by the current medical needs? And we also, in addition to looking at that sort of that sense of how is this going to impact the length of life, we're also going to look at how is this going to impact functioning over the long term. What's the level of chronicity of the current medical conditions, right? So, you know, a child who has a very significant fall and shatters her elbow maybe in hospital, and there may be acute medical needs, but that's not going to be a chronic condition, right? Many of the kids that you're working with are kids who have significant conditions that are likely to impact them over the long term. So questions to talk about are, is the child going to recover from the current medical concerns? How long will treatment be needed? And will the condition involve a high likelihood or imminent risk of restrictive placement if supports are not strongly in place? The other two items, right, I want to actually skip down to the second item on this slide because I want to focus on impairment and functioning quite strongly. So intensity of treatment, right, remember that's in criterion 1, and that's a how much, how intense, meaning how invasive, right, and how many services and supports are required, right? And so we think broadly about this. We're thinking about appointments, medications, skilled and paraprofessional supports, medical equipment, right? What is required for the child to function, survive, thrive, right? That's what we're looking at there. Now let's go back to the impairment and functioning item. This is a linchpin item for the HCBS medically fragile determination algorithm. Okay, and so it's really important that we sort of focus in on this item and think about it carefully, because when we look at this item, remember we talked about criterion 1 or 2, it's or, right? You can get through those doors in 2 different ways, but you also have to look at impairment and functioning, right? That's an and, that has to be present. But remember also that we talked about we don't want to provide too many services. We want the right dose of services, right? So let's go back to that wheelchair example. When we know that Charles is in a wheelchair, we don't know what his functioning is like. When we're told that Charles needs support for all activities of daily living, we now know that there actually is evidence for an impairment of functioning. So we want to ask ourselves, what's the amount of interference with participation in daily life, right? Day-to-day life functioning, healthy development that's caused by the conditions. And so some of the assessment questions and the detective questions can include, what's the level of participation that the child has in family life, in school, in relationships with peers, and other developmentally appropriate activities? And what kind of support does the child need to successfully participate in these day-to-day activities? This is really, for the medically fragile kids, this is the linchpin of HCBS services. Our point of these services is to make sure that kids who have impairment in day-to-day functioning that gets in the way of them succeeding in life get the supports that they need. But we don't want to rate this if it's not true, right? So this is a really important item to be thinking about. So we're going to look at an example of this, right? This is Ahmad. He's an 18-year-old person. He's a young guy, and he has a serious progressive lung disease, which puts him at risk of an early death. He has ongoing medical care, right? He has great difficulty with breathing, and he's immune compromised. So he can't participate in physical activities or the social events that other kids his age, other young people his age participate in. Ahmad needs daily treatment, including chest percussion, breathing treatments, and appointments with a pulmonologist for med adjustments once a month. Okay, so let's think about some of the items we just looked at from the medical module. And folks, let's try chatting in some of the items you're seeing possible evidence for here. What would you be tempted to think about? What would you want information about? What are some of the ratings that you're thinking about here, right? So, right, Brianna's typing in there, it's a life-threatening issue. It's a chronic issue, right? This is, chronicity, right? So we definitely know that. How about impairment in functioning? Do we see, intensity, right? It's not a high level of invasive intensity, but he does need ongoing treatment. So what about that critical impairment of functioning item? Do you see evidence that Ahmad's condition gets in the way of him to participating in day-to-day life that would be typical of an 18-year-old man? Yes, okay, here we go, right. He can't participate in typical activity. He's impaired in multiple functional domains. Good, right? So we're not gonna assume from the first 2 lines of this story that we know anything about Ahmad's actual functioning, right? We need to make sure that we are detectives about what he is and isn't able to do. Good. All right, so now we're gonna switch into that second piece that feeds into the Med-Frag determination, and that is self-care activities of daily living, right? And again, remember that we selectively pull items for these algorithms that tend to be more predictive of the need for restrictive placement, right? So we're looking at 4 key items here. Eating, right? So this is not eating disturbance like we talked about in the risk behaviors. This has to do with what kinds of medical supports and challenges are present associated with getting adequate calories into the body, right? So this can be kids who require supplements nutritionally, right? Kids who have textural issues, kids who can't swallow well, kids who have feeding tubes, right? All kinds of challenges, right? The same with toileting, right? So for the 6 to 21 version, we call this toileting. I think for you nurses, it helps to think about the item name for the 0 to 5 version, which is elimination, right? And so these are challenges with elimination of waste from the body that can impact day-to-day functioning, okay? And then those critical areas, right? The child's capacity to move, right? To move around the environment, to position the body and limbs, that core piece while stationary, right? And to use the limbs in that organized way, and also transferring, right? The capacity to move from place to place, but this is really thinking about things like moving from bed to chair, from chair to chair, right? Those kinds of transferring issues. And these are issues that when the appropriate supports are not in place can put children at risk, right? Physically, and can put the context at risk for restrictive placement because they can be challenging to manage without the appropriate medical supports. So let's look at an example. This is Bella. She's 12. She has a tracheostomy and a gastrostomy tube. I think we used this yesterday for one of the key characteristics. She's nonverbal, non-ambulatory, and she depends totally on others for self-care activities. She can't attend school without a one-to-one aide and nursing services, in part because she needs specialized medical equipment to keep her head up. So let's think about those 4 items we just talked about. Any evidence that Bella needs significant medical support for eating? Right, she definitely has a gastrostomy tube, right? What about any evidence that right from this is a shortened version of yesterday's example, any evidence that she has any issues with elimination? No, right, we don't have that evidence. I think in yesterday's version of Bella, we did have some information about this, but no, we don't know that yet, right? Rebecca says no, but knowing what you know about her, you know she could possibly, so you would need more information, Catherine is saying, great, right? Okay, what about evidence for problems with mobility? Would we rate her on mobility? Yes, right. She's non-ambulatory, and that is a really important piece of information. What about positioning? Yeah, right. She needs a significant amount of support to keep her head up. And what about transferring? Yes, right. So in this simple bit of information, we know that this is a child with significant level of need in the self-care activities of daily living. Good job, everybody. Okay, so we've been through all of the items that feed into the determination, and we're going to spend a little bit of time talking about organizing your findings of your assessment into a focused care plan or coordination plan. But before we move forward, I want to check in. Any concepts you want to go back to? Any questions about the items? Great, Brianna, that's a great question. How do we rate infants in mobility and positioning? We take development into account and we rate the infant according to what would be expected at their stage of development, right? So that means you're going to have some reliable information on developmental stages of mobility and positioning, right? So for infants, right, it's moving from right laying down to rolling over to being able to pull up to being able to sit with the core and position oneself, and from the core positioning that leads to full mobility, right? But that developmental progression happens in a pretty predictable set of stages with rough timelines, not exact, and that's something we sort of need to know about when we're thinking about infants. Good question, Brianna. Any other questions about content? Okay, remember, if you're cogitating on these items today and you decide you have some examples or some questions that you want us to answer tomorrow, get those to us before 5 o'clock today, and we will work them into tomorrow's Q&A webinar. You also can just come into the webinar tomorrow and shoot out some questions, right? Carolyn's asking for newborn ratings for these. And so, right, a newborn, right, we're not going to rate, we're going to rate no evidence, right, for many of these things. Okay, so one thing that brings up a really good point, Carolyn, thanks for asking that question. Remember when I showed you the action level slide yesterday, and I said to you, a 0 does not mean that we know for sure that there's not a need, right? A 0 means we have no evidence for that need. So when we have an item that we cannot rate because a child is newborn, right, we would rate that no evidence for a need. And that simply means this is not what we're going to be working on right now. But it doesn't mean we know for sure there's never going to be a problem, right? That's why assessments are updated so frequently when children are growing and changing, because we know that these things can emerge over time. Great question. I hear somebody turning on their mic. Someone wanting to say something? No? Okay. All right. So we've got about 40 minutes left. We're going to switch over now to coordinating care with what you learn about a young person, right? That's a big piece of your role. And we're going to sort of run you through what we call a TCOM care planning roadmap, okay? We're going to do that pretty quickly today, but we want to give you a taste of what it can look like to use some of the information and collaborative strategies that we've been talking about to get a nice targeted plan together that sets you up to monitor progress collaboratively with all of the stakeholders on that team we talked about yesterday, okay? Now, we had given you a little bit of homework, and this is time to pull that homework out. We talked about Charles, right, and yesterday, and we also sent you a more full version of Charles's story. So it'd be helpful to you. I think we had suggested print it out if you can print at home and follow along, because we're going to use Charles as an example of how we might implement this roadmap. So let's just give ourselves a little refresher. Charles, we know, is 17 years old. He has significant multiple medical challenges. He's wheelchair dependent, relies completely upon caregivers for self-care and medical care. He understands his disease is progressive and will result in premature death, and he does have some anger and fear about this. That's pretty appropriate, right? Secondary to his diagnosis, he has a lot of pain in his legs, right? So we had talked yesterday about some of the ratings that would lead to HCBS determination, right? He would definitely have ratings on criterion 2 for the MedFrage algorithm and on that life-threatening item, right? We talked yesterday about Charles's strengths, right? He has an accessible apartment. He's got deep connections to family. He does have a situation with his father that is, appears to be, he doesn't care about it, but it appears to have some challenge associated with it because his father has rejected Charles or moved out of his life in a volitional way, right? And then we talked about some of the functional struggles that Charles has. He struggles with insomnia and anxiety. He's often awake at night. This awake at night piece gets in the way of his participation in school, getting to school, and achieving in school, although he says he likes school. Mom says he has some friends, but he has a difficult time maintaining friendships because he doesn't really understand good boundaries, and he's often upset when friends choose to spend time with other people or don't want to do the things he wants them to do. So we have some actionable needs that are outside of, actually, if some of them are in and some of them are outside of the needs that you would rate for the determination, but it's important contextual information that you would need to have whether or not you rate that information. So let's say you have your HCBS ratings for Charles, you have your information for Charles, and you need now to move toward that part where you start to pull goals together. We're going to walk you through a nice way to organize that for yourselves. So we're going to start with this document that we call the relevant item grid. Now, this is the flip side of a care planning document that you can get from, I think we sent it out to you as part of the handouts, but also you can always get a PDF copy of this on the Institute website, and it's also available in the supplemental materials in your TCOM training, in your CAMS training course on the TCOM site. But this is a nice way to start organizing your thinking, and most importantly, the thinking of your team. Remember, we talked about you as that umpire, or that, I like it better to think about myself as a manager when I'm thinking about care coordination, right? So this is a nice way to start organizing the strengths and the needs in order to build a focused plan of care. So the useful strengths are any strengths the child has that the child can draw from, right? And any of the caregiver strengths, right, that we see as we get to know the caregiver, right? And then the strengths to build are strengths that are 2s and 3s. So remember, we talked about relationship stability and social relationships with adults. If we had a 2 or 3 on there, we would pop them into this box. Down below, then we organize the needs for the child and youth. For you all, you have some 2s and 3s that are associated with either, right, the medical health issues or the trauma and behavioral health issues, right? Depending on which population, right? We would pop those here. Any 2s or 3s actionable needs that we've identified for the caregiver. So this becomes a sort of a visual organization and a kind of a summary of everything that we have learned about the child, right? So here's just a quick review of those definitions, right? What I just walked you through, right? These are the ways we want to start organizing our thinking. Remember, we talked about our information as a closet organizer. So here, right, when I say ones on aces, that applies to the full cans, but I want you to translate that into thinking about when I organize the needs of the consumer, the young person, I need to make sure I put trauma into those needs so that I always have that trauma-focused filter as I move forward with my work. Right? And then obviously, right, we talked about the caregiver. So this is kind of a way to organize things, right? So we start there. We've got everything organized. And now we have an important step before we start moving these chess pieces around to build goals, okay? And that is that collaborative piece of building a shared vision, okay? So we cannot emphasize this enough. And yesterday, a lot of the questions that came up were questions about how do I approach this subject? How do I build consensus? How do I negotiate when sensitive information is creating tension in the family that I'm serving? How do I figure it out when a provider says something different from what a caregiver says, right? We talked a lot, and we're going to talk tomorrow in tomorrow's webinar about building consensus. Well, this is another important preparatory piece, right? Remember we said, educate people about the action level language, right? Give people an understanding of what you're doing, and then consensus is easier to build. Well, guess what? When you take the time to develop a shared vision before you set up goals, same thing starts to happen. We're able to collaborate more deeply, we're able to monitor progress more clearly, and we're able to negotiate disagreement. So we start with a shared vision statement, right? The youth and family, we want to talk with them about where do you see yourself when we finish with this work, right? And that really is, where do we want to be, right? Where we are now, you've already done, right? You've done your assessment and you've organized those needs and strengths. But remember, we talked about how much easier it is to build consensus when we're talking about forward motion. We are talking about difficult information together because we want to help move forward. So where is it that you want to be, okay? What will you have achieved, and what will change look like for you, okay? That is the shared vision that then you start building goals out of, and goals is, how are we going to get there? Right? And in order to put those things together, right, you're going to start identifying cause and effect relationships. So let's think for a minute about Jay. We're going to think about Charles for a minute. But when we think about Jay, remember, he was that 15-year-old who was very anxious and panicky, had gotten into substance use and self-injury as a result of his anxiety symptoms, right? Well, what if the family says, I want him to stop using drugs, and I want him to stop stealing his aunt's lorazepam, okay? And Jay says, I just want to feel better, okay? That's where we start pulling in those multiple perspectives, and we say, okay, so where we are right now is that, Jay, you're feeling really anxious and you're uncomfortable and you want to feel better. Mom and aunt, you're feeling really upset about his substance use and worried about it, and you don't want him stealing your lorazepam, right? And what we've got to start thinking about is, how are those things linked? Those are those cause and effect relationships. So we talked about, for Jay, they're linked because Jay is using substances to calm himself down. So what about Charles, right? If we think about how Charles and his family might talk about a shared vision, right? They might say that we'd like to see him experience relief from the pain he's having, the anxiety he's challenged by, and an improved overall quality of life, Okay. They might also say that they're struggling with their deep connection with him and the fact that his life will be shortened. It seems like that story talks a lot about that. And we want emotional and practical support to maximize the quality of our time with him. But we also heard mom express a concern about his success with peers and age appropriate activities. And that might be a place where we would do some work. So we get that shared vision. We have those organized needs and strengths, right? How do we piece those two things together in a set of goals? Well, we start by those questions, right, that can help us focus. And we're going to start clustering the needs and strengths in response to these questions. So for Jay, right, what change will happen? Jay's anxiety will improve and his substance abuse will reduce. For Charles's psychiatric challenges will be supported and his pain will be reduced. He'll become more effective with his peers, right? And his family will get support around their interactions with him and their emotions about him. We'd start asking Charles and his family to think about the barriers to meeting those goals. And that's how we start to build those cause and effect relationships. And then we start honing in on the root cause barriers, right? So for Jay, clearly anxiety is a root cause. And for Charles, right, there are a couple of root causes, right? One is he's got a significant diagnosis that's going to shorten his life. And he needs some support around managing that and coping with that. And another seems to be, right, his social skills and his capacity to interact with peers, okay? If we target those with activities or interventions, what are some of the other things that will improve as a result and what strengths are there, right? You can use that care planning worksheet that we talked about to help facilitate that discussion. And if you stay on a structured checklist approach to the eligibility determination items, how are we going to deal with your anxiety? How are we going to deal with your depression? You're actually going to shut this creative conversation down. So you want to really take the time to have this more free-ranging conversation with family, youth, and other stakeholders to get a sense of how to build a goal that everybody can buy into and that is set up for more success. So how would we do this for Charles, right? So this is an example of, right, all of the items that we rated, plus some of the items that you wouldn't have rated, right? But even if you don't rate the full cans, you could list needs in here that are outside of the eligibility determination that you found out about in your comprehensive assessment process. So we start with this organization, and I would actually advocate that you organize this with the family and the youth, and or that you set it up ahead of time and then put it in front of them and say, is there anything we're missing here? Anything you would add or take away? It starts us out in a really like we're all on the same page. It's fully transparent and we're working with the same information. And then we begin to cluster, right? So we think about what are the background needs, right? For Charles, these are needs that we cannot change, not needs that we don't want to change, not needs that we don't have the services to change, but needs that actually can't change. We can't take away his medical diagnosis, right? Things that go in this category, background needs, are things like the presence of a trauma history. We can't take away a trauma history. We can treat and change trauma symptoms, but we can't take the trauma away. Same with the developmental delay. We can't actually take away a significant developmental delay, but we can target the functional sequela of that delay. So those are needs that we cannot change, but we don't ignore them. Those are the lens through which we do our work, right? We have to keep them on the forefront of, okay, this is the lens we work through. And then we get to what we call the target needs or the prioritized needs. And remember, we talked about what are the root causes, the barriers to achieving your vision of transformation that we've identified in that shared vision. Here are some of those that we would put for Charles, right, that we might want to target with service referrals and coordination, right? And we also have another piece, right, and this is where that elegant clustering comes in. What are some of the needs that might improve if we're effective with those target needs? We don't have to make a referral for every need we've identified. If we make a good hypothesis with the consumer and the family about cause and effect, then we can actually have some dominoes that will fall, right, if the target needs are successfully interacted with. And so for Charles, right, if his anxiety and his emotional response to his diagnosis and his pain are addressed, we may well see improvements in his sleep and his optimism and even in his adaptability, because we know that pain can really interfere with that, right? If we get to the root of that anxiety and that pain, his school behavior, school participation might improve, right? And if we build his peer interaction skills, right, his social relationships with peers will improve. And if we target parenting stress and the family's response to his diagnosis, they're better able to support improvement in all of the target needs and also all of the anticipated outcomes. I just want to pause for a minute and sort of get a sense of questions, reactions. Is this a helpful way to frame your thinking about service coordination? Is it challenging? What are you thinking about this approach? I've got some crickets. Very helpful, Yura says. She likes the approach. So one of the things I want to mention here too, definitely helpful, great, good, is that there's a reason why, right? So Ali is saying it can be difficult at times, and I like the explanation, right? And that's why we emphasize the importance of using these tools as a closet organizer. You're working with complex needs, folks. One of the challenges in the literature and the research on when we're effective versus when we're not is that we don't get focused, and we don't get focused in a collaborative way that prioritizes the needs of the consumer, right? So this whole approach brings the consumer and the key stakeholders to the table. That's important, but it's equally important that everybody collaborate on a really focused approach so we all know what we're doing and where we're going. Such an important piece of your work. So the last piece then, sort of building that care plan, is bringing in the supports to target the needs we've identified. So we're going to choose activities and services that address those target needs. So this is where you'll hear my soapbox, which is that you want to be able to say, when we ask you, what target need will improve as a result of your intervention? Okay, so Josh has heard me tell the story many times. I work with a state where, like New York, right? Some parts of New York, it's very remote and services can be scarce, right? And there's one county in that state where there's very little in the way of mental health services, but there's a kennel that trains therapy dogs. So lots of therapy dogs in that county. So just about every kid in that county, when you look at their treatment plan, has a therapy dog. Okay, so while I love the idea of a golden retriever for everybody, particularly now in the COVID-19 context, we could all use a puppy or kitten to cheer us up. I know that therapy animals are evidence-based for certain challenges and not for others, right? So what we want to be able to do is get more specific than that. We want to say, I have put this therapy dog in place because the therapy dog is being trained to support the motor challenges of the consumer. Or I have put this therapy dog in place because there's an evidence base behind contact with a therapy animal and trauma symptoms help in therapy, right? Kids can participate in trauma-focused therapy more successfully actually when a therapy dog is present. So we want you to be getting highly specific about what it is that you're doing. And just a little note, I'm going to ask you to get that specific in a minute for Charles when we get to the final piece of his care coordination plan. Cross-check for strengths, right? So when you're putting activities and services and supports in place, don't forget to think about the strengths that are useful in the child's life. Don't pull a child out of the family context and provide skill building separately if the family is terrifically connected and very good at coaching. Give them all the skill building work and let them work on it full time at home, right? Because that is really building upon a strength. Build strengths, right? For Charles, when we saw the adaptability piece and the social skills piece, we want to make sure and build strengths while we're teaching him. Part of social skills is being adaptable to the vagaries of other people's needs, right? Make sure you're cross-checking with those absent strengths. Okay, so we're going to do a little quick group exercise. We're going to put up sort of an organized structure for Charles. Here are his needs organized, and you'll see that I've left one area blank. So we've got Charles's background need, that's his medical diagnosis. We've sort of clustered his target needs in areas that link naturally to one or two interventions, right? Because we don't want to put one intervention in place for each of these. So we've got one area which is sort of his and his family's emotional responses to his diagnosis, right? And then we've got his pain and the complexity of his care in one category, and then we've got his peer interactions in another category. And over to the right, you can see we've got some things that we think might improve if we can target those needs. Okay, CES evaluators, I want to know, what are some of the activities and interventions that you would put in the first box? What are some things you might refer or recommend for the behavioral health, parenting stress, emotional response piece of Charles's target needs? Just chat those ideas into the box. And remember, no wrong answers here, right? We just want to generate some brainstorming. What are some things that you might recommend there? Palliative music therapy. Right, so palliative therapy has significant components of support for a terminal diagnosis. Nice, peer and parents, peer support, caregiver family support and services. Great, right? So we're talking about, for this area, moving in and providing some of the evidence-based practices that we know help people manage a really challenging emotional reality. Right? I love the way your respite is another possibility for the parenting stress, right? Giving them some time off, particularly because we're hearing that the family is providing the preponderance of the day-to-day care. Good. Okay, nice. I love that you're using caregiver, peer, and peer support. I just love those services, and we know that sometimes when things are genuinely challenging, those who have walked the walk can be the best support and the best strategizer on ways to manage things, and so I love that you're relying on that. Okay, let's move down a box. You're going to teach me now. You're all nurses, so you tell me, what would you do about his medical needs, particularly with a focus on managing that pain? What are some of the places you might want to make sure to connect Charles with services? So palliative care again, right? That palliative care paradigm really does have that nice piece of comfort, pain management, emotional response management, right? Really lovely modern model. Someone else, Catherine, is saying pain management and massage, right? That's a creative place to help try and alleviate some of his symptoms. Good. All right, last but not least, what kind of activities would you recommend for his peer interactions? We want to see his peer interactions improve so he builds good social relationships. What might that look like? What do you think he might benefit from here? Day-hab, right? Maybe some kind of structured supportive program where he's out, and he's getting to be old enough for that, right? Community self-advocacy training, yeah, that's a great example of a way to sort of respect his young adult status, but start teaching him how to be more effective. It's a lovely frame. You're not coming at him and saying, let's give you some social skills training. We're saying, let's give you some skills on, you're getting to be a young man now, how to advocate for yourself effectively. Respite as well. Now, respite will not build his skills, right? So we would want some sort of structured respite where he has the opportunity to interact with support around peer interactions. Great, good job. Nice care coordination, nice care planning. Okay, so just remember, right, we want to make sure you're using those strengths and you're building those strengths, right? And all of what you've identified really incorporates that in. And I love, Yura recommended the community self-advocacy training, right? And if you look at the red strengths to build, you really can see how that self-advocacy training could build all of those strengths, right? That's a terrific protocol for young adults. Okay, so that's our care planning model in a nutshell. Really quick review. Any questions that you have about that? Or any comments you want to make about that approach? Okay, so remember, we really want to hear from you today. We're going to be working on a really short leash because we're doing this webinar again from 1 to 4, and then we're going to try and organize all of your questions for tomorrow and think through how we want to approach it. So I know you're very busy, but if you could take some time before 4 o'clock today, if you have questions, just email Josh or I know because he is a multitasker, he is texting in our emails as we speak. So you can email either one or both of us directly with any questions you'd like us to answer. You're gonna think about today's presentation and you might come up with more questions, and feel free to reach out to us. We're also going to talk tomorrow about supports. We're going to show you the CANS Institute website and some of the learning supports that are there or that are coming. So we're going to do some of that work tomorrow. But also feel free, if your day gets away from you and you just come in tomorrow morning or tomorrow afternoon to webinar 3 with some questions, we're going to encourage you to chat those out. We can try and handle those with you on the fly. And I'm going to remember to come back to that question about virtual resources that someone threw out today.